आज हम बात करेंगे कोलिलिथियासिस या गॉल स्टोन डिजीज, गॉल ब्लैडर स्टोन। गॉल ब्लैडर एक बहुत इंपॉर्टेंट पार्ट होता है लीवर और बिलियरी सिस्टम का। इसकी एनाटॉमी पे आते हैं। गॉल ब्लैडर receives bile from liver and it stores. There are intrahepatic biliary radicals which drains into right and left hepatic duct and which confluence become hepatic duct, and from there cystic duct joins hepatic duct to form common biliary duct. After that, common biliary duct drains into second part of the duodenum along with pancreatic duct. Gallbladder is a storage organ which consists of fundus, body, Hartmann's pouch, neck, and cystic duct. Gallbladder arterial supply is cystic artery. गॉलस्टोन डिजीज काफी ज्यादा कॉमन हो गई है इंडिया में। इसके कॉजेज भी हैं काफी और पैथोफिजियोलॉजी में है। दो तरह के गॉलस्टोन, पिगमेंट स्टोन एंड कोलेस्ट्रॉल स्टोन। पिगमेंट स्टोन कैन बी ब्लैक और ब्राउन और मोस्टली फाउंड इन एशियन पॉपुलेशन, whereas cholesterol stone is pure cholesterol or mixed stone. It is most commonly found in United States population. Pathogenesis of cholesterol stone. There are three stages in the formation of cholesterol stone. There is cholesterol saturation, that is lithogenic bile. There is nucleation, and then stone growth. Three essential elements. There was stasis. Third factor is element is stasis. First is lithogenic bile. Second is nucleation. Third is stasis. Pigment stones. Pigment stones are due to altered solubilization of unconjugated bilirubin induced by bacterial infection. Bacteria secretes a specific enzymes, beta-glucuronidase, precipitation that causes precipitations of calcium bilirubinate, and that forms insoluble salts. Ultimately, pigment stones are formed. Pigment stone can be caused by hemolytic anemia in children's and due to cirrhosis. In cirrhosis, there is hypersplenism. Splenics works more, and because of hypersplenism, there is hemolysis, and that causes pigment stone. Clinical feature. क्या क्या साइन एंड सिम्टम्स लेके मरीज हमारे पास आता है। गॉल ब्लैडर की एनाटॉमिकल पोजीशन है राइट अपर क्वाड्रेंट ऑफ द एब्डोमेन, जस्ट बिलो द लीवर। Murphy's points in a mid-clavicular line at the tip of the ninth rib. So, patient typically presents with intermittent episodes of biliary colic in right upper quadrant of the abdomen. There can be mid-epigastrium pain also. When there is associated cholecystitis, the pain becomes intense and progressive in nature and continuous, and it radiates to back towards right scapula and referred to right shoulder. There can be associated anorexia, nausea, vomiting. There can be low-grade fever also. Murphy sign is positive. There is tenderness at Murphy's point, guarding and rebound tenderness. अगर अटैक्स बार बार होते हैं तो पेशेंट कैन गो इनटू क्रोनिक कोलिसिटाइटिस। उसके साइंस ज्यादा डिस्पेप्सिया वाले होते हैं। देयर कैन बी एक्सेसिव ब्लॉटिंग और फ्लैटस. देयर कैन बी एपिगैस्ट्रिक burning sensation. There can be nausea, vomiting. There can be fullness, discomfort, and intolerance to fatty food. There can be pain maybe due to sometimes maybe due to stone impacted in Hartmann's pouch that leads to obstruction of cystic bile secretion, and excessive mucus is secreted and forms mucocele. There is a distended gallbladder which can be palpable also. If this mucocele becomes infected, it forms empyema of the gallbladder, and sometimes because of distension or in some comorbid conditions, distended wall can necrose and gallbladder can perforate, and it can form fistula also with colon or small bowel. There are lots of associated complications also because of gallstone. There can be ascending cholangitis. There is a typical features of ascending cholangitis. This is Charcot's triad. There is pain, jaundice, and rigors. There can be biliary stones also, common bile duct stone, which cause obstructive jaundice. Now coming to the management. So first of all, whenever patient present, first thing is to revive patient, replace fluids, give analgesics, give antibiotics, and confirm diagnosis by ultrasonography. We require TLC count also because there is leukocytosis, and we require liver function test also to rule out obstructive jaundice. If there is obstructive jaundice, then we have to do MRCP, or we can do ERCP to treat the condition also, because there are stones in CBD which causing obstruction. Now coming to the definitive treatment of the cholelithiasis. Gold standard of treatment is cholecystectomy. It can be done by open method or laparoscopic method. So today also I discussed a very common disease, cholelithiasis. Why? So question is why we are operating in these kind of condition, because इतनी सारी परेशानियां हैं. We can have obstructive jaundice, pancreatitis, and there are perforation also in rare cases. Most of the cases, as I discussed earlier, asymptomatic. So thanks very much, and I think you just continue watching my video, and I will share more informations and more diseases with you. Thank you very much. Bye.